The video shows our experience about the laparoscopic thermoablation for patients with problematic hepatocellular carcinoma. But what is the problematic hepatocellular carcinoma for a percutaneous approach? Lesions not visible at percutaneous US examination, lesions in the hepatic dome, lesions in the 7 segment, lesions adjacent to large vessels or intrahepatic biliary ducts. Lesions in subglisonian position, lesions located on the liver surface contiguous to intestinal or gastric wall, lesions located on 4 round 5 segments contiguous to gallbladder. The first step is the setup of a peritory room requiring adequate laparoscopic and ultrasound equipment. Patients with lesions not visible at percutaneous ultrasound which are located deeply in the liver dome and in the 7 segment require different positioning. Generally, position of the patient is supine on the operating room with the left arm extended. Patients with tumors in posterior segments can be placed in either an oblique position or left decubitus position. Above all, for these locations, it is necessary to perform an accurate preoperative CT scan evaluation. The dome of the liver may be difficult to examine because of the lack of adequate contact between the probe and the convex liver surface. This can be overcome by instilling saline solution and scanning the highest part of the organ through the fluid, water immersion method. For lesions located at posterior segments, it is necessary to insert the electrode on the liver surface further than the lesion. In this case, the transducer cannot visualize contemporarily the tumor and the electrode tip. The electrode must be positioned near the transducer of the ultrasound probe in order to introduce it slightly oblique to the transducer and with an acute angle to the axis of the probe. In these cases, problematic nodule could show a less rate of total necrosis, increasing the risk of complications, also through the laparoscopic approach. This is evident for the tumors located in the 7 segment. When the percutaneous procedure is unfeasible, this can be considered a problematic situation also for the laparoscopic approach, influencing the immediate results in terms of total necrosis at 1 month CT scan. On the other hand, for lesions in the liver dome, there are not differences in comparison with the other locations in terms of total necrosis, local recurrences and complications. In this setting, the laparoscopic approach is able to obtain similar results to those obtained by percutaneous ablation for feasible lesions. For the other group of problematic tumor location, one of the most important sites is the nodule near the hilum. In this setting, thermoablation may cause bile duct stenosis due to physical or heat damage to the bile duct. In order to protect the biliary ducts, the needle is inserted with a cranial to caudal angle and an irrigator with cold saline solution infuses some gauzes placed around the hepatoduodenal ligament. Cold vascular flow in the portal and arterial systems protects the bile ducts from the thermal effects. In this way, we obtained good results in terms of ablation without increasing the risk of complications. Superficial lesions are the best indication for the laparoscopic approach. Also, for esophageal lesions, it is possible to perform ablation without risk of nodule rupture. It is important to insert the needle into the lesion through the liver parenchyma. For superficial lesions, it is possible to obtain the best results in terms of local recurrences and technique effectiveness. As well as for superficial lesions near to visceral stomach or colon, using irrigated gauze, it is possible to protect the contiguous structures, obtaining low rates of local recurrences and complications. Also for lesions near the gallbladder, the laparoscopic approach guarantees good results. The presence of gallbladder do not prevent the ablation effect on the nodule. In some cases, it is necessary to associate the cholecystectomy due to the thermal damage of the gallbladder wall. It has been shown that spread of hepatocellular carcinoma may occur by the portal route. So, the lesion should be removed along with the involved portal venous bifurcation, such as guided liver resection for hepatocellular carcinoma may reduce the risk of local recurrence. Intrahepatic vascular occlusion, mimicking the segmentary resection, is accomplished in this way. Ultrasound identifies feeding vessel, electrode burns and occludes this vessel, obtaining the subsegment devascularization. First step is accomplished to evaluate the tumor vascularization and to identify the feeding vessel of the lesion. Using ultrasonographic guidance, the electrode was directed towards this area with direct puncture of the nearby blood vessel, and the ablation cycle lasted either 2-4 minutes using radio frequency or 60-90 seconds using microwave ablation. Another evaluation with color Doppler imaging could be performed to confirm a coagulative ablation of the vascular area. In any case, a discolored area on the liver surface can be easily visualized. Then, the lesion is treated with the insertion of the electrode in the usual way. Nevertheless, the problematic locations of these HCC nodules, often in dangerous positions, severe complications rates are low, particularly those due to technical problems as trochohematoma, biliary fistula and visceral perforation. Bleeding from the trocha could be important and require a re-operation to stop the hemorrhage. On the other hand, during the procedure, bleeding at the extraction of the needle could be evident. But these superficial hemorrhages could be easily managed by bipolar coagulation. In one case, during the treatment of a lesion located in the fourth segment near the hilum, a biliary fistula occurred and it has been recognized during the operation. Probably, the needle produced a biliary lesion during its passage. A postoperative endoscopic procedure with a nasobiliary drainage solves the problem. In another case, a lesion located in the surface of sixth segment has been treated by microwave ablation. Adhesions due to previous operations between the liver and the abdominal wall and viscera are taken down using ultrasonic coagulator and bipolar forceps. Unfortunately, postoperative period was complicated by duodenal perforation, probably due to the adhesions dissections. Duodenal perforation has been successfully treated by a laparoscopic suture. In the treatment of hepatocellular carcinoma, laparoscopic thermoablation proved to be a safe and effective technique, as it permits to successfully treat neoplastic nodules in inconvenient locations, not manageable by percutaneous approach, with a low morbidity rate.